Welcome to the Mama So Fit podcast. This is part 2 of our perineal laceration and tears series, where we're interviewing pellet floor physical therapist Hayley Kava. Hayley Kava is one of our favorite pellet floor physical therapists, and in last week's episode, we talked all about what are the different types of tears and lacerations that you can have, what each of those may mean for your recovery, what percentage of us may have each of these tears. We also talked about what you can kind of expect with the repair after you have a tear and what that initial time frame may look like for you. And we talked about ways that you could possibly prevent tearing or at least decrease the severity during your birth. So if you want to learn all about that stuff, be sure to tune into last week's episode and then maybe tune into this one, because it would probably make more sense if you listen to last week's and then this week's one, because this is a continuation of last week's episode. In this week, we're going to be talking about operative vaginal delivery, which is the use of an episiotomy, forceps, or vacuum to assist with a vaginal delivery. Why you may want to opt for one of those, why you may not want to, but most importantly, how that type of delivery may impact your pelvic floor and your perineal health after birth. We also talk about what you can do to recover after birth if you have a vaginal birth, what that may look like if you did have a laceration, how to approach mobilizing that tissue again, and different things that you can introduce within the first few weeks postpartum to help enhance your healing. So we hope you enjoy this episode. If you didn't catch last week's, be sure to check that one out as well, so you can learn all about what to expect after a vaginal birth. Welcome to the Mama Stay Fit podcast. This is Gina, perinatal fitness trainer and birth doula.
And I'm Roxanne, labor and delivery nurse and student midwife.
And this is the Mama Stay Fit podcast, where we empower you on your prenatal fitness, birth, and postpartum return to fitness journey.
Our podcast shares how to move throughout your pregnancy to stay strong and comfortable, because pain is not a requirement of pregnancy. Understand the science of birth and how to approach recovery after birth.
We share our personal experience as mothers navigating this stage in our lives, plus our professional expertise as birth workers and fitness professionals.
Our goal is to help you feel confident as you navigate the perinatal timeframe for an empowering pregnancy, positive birth, and postpartum journey.
We are glad to have you with us on this journey and that you have chosen us to support you. So now that we've talked a lot about all the tears and repairs, let's talk about a few things that we can possibly do to decrease tearing and or potentially alleviate it. And I do want to start with, sometimes there's nothing that you can do. Like baby might just like elbow their way out, like they can be in a really funky position. Like you may need an instrument-assisted delivery. So sometimes there's nothing that we can do to prevent a tear. And so if you do tear, it is not your fault. There is a lot that we can do to repair it and to rehab from it. At one point, we said it's not the end of the world, but for some folks, it feels like the end of the world if you do tear. And so we're really cautious with using that language, but know that there is hope. It's not a hopeless situation by any means. But the most important thing that I have found influences whether or not someone tears is whether or not their provider believes that people don't have to tear at birth. If they believe that everyone tears and there's nothing that we can do about it, you will probably have a vaginal tear. And the way to kind of tell because it's hard to figure out beforehand sometimes whether or not your provider believes that people don't tear, is when your baby is crowning, if they tell you to push as hard as you can, they believe that everyone tears. And there's a good likelihood that you will probably tear if you shoot your baby out. Now, the things that I find to be very helpful to help decrease the severity of tears or even alleviate it altogether is I saw some midwives do this at one of our local hospitals, and I was like, that makes so much sense. And it's been really successful for my clients, is when your baby is beginning to crown, relax your legs. Like don't pull them as wide as you can. Don't internally rotate as much as you can. Just allow them to release tension, because there's only so much tensile strength that our tissues have. And so if we have our perineum stretched already to max capacity, and then we add our big old baby head, we're probably going to tear. And so what I found to be really helpful is just to relax the legs, and that helps the tissue stretch a little bit more easily. The next thing that I find to be really successful is to just slow down. Just the baby will come out. If your baby is crowning, your uterus will just shove it out. Like you don't really need to do anything. You can do like little pushes. Like usually I say like pretend like you're blowing a candle out on the other side of the room. You can stick your tongue out and pant. You can just kind of like we're still like kind of pushing, but we're really just like wasting time until your body expels your baby's head. If you have a provider that believes that not everyone has to tear, they will cue you at this time to slow down. And they'll probably have some external pressure on the perineum with like a warm compress. They will tell you to like just breathe now, like let's ease the baby out. And then the likelihood of you having a more severe tear is, I find, to be a lot less. The third thing that you can do, and not everybody wants to do this, and it's okay if you don't, is you can touch your baby's head. Like you could reach down and you could touch your baby's head and you could help kind of ease them out as well, where you're like, wow, there's a lot of head right there. I will just slow down a little bit. If you're unmedicated, you'll kind of know that your baby is about to crown. And this happened to me during my last birth, where I was like, I'm crowning, and I was not crowning yet, but there was a lot going on. And Roxanne was like, Gina, push. And I was like, shh, I'm easing my baby out. And she's like, you've got a little bit more to go.
There was like 2 centimeters of her
but
head.
I didn't tear, so.
Yeah, so obviously that's the key to slow down when you can
slow
see
down
this much of your baby.
But those are the 3 things that I find to be really helpful to decrease the risk of tearing is, well, I guess 4 things. 1, having a provider that believes that not everybody has to tear, who is going to try to assist you in not tearing with like warm compresses, applying some external pressure, cueing you when to slow down, relaxing your legs, slowing down, panting, like just wasting time until your body pushes your baby out, and then touching your baby's head is like another really like cue that can also be very helpful for folks. But you can also do all of those things and still have a tear. And it's okay if it does happen. Like, again, we have the ability to repair them very well. We have the ability to get rehab and to help recover from it, which is a lot of what we're going to be talking about in this episode as well. Is there anything else that either of you have experience with helping to prevent tearing? And I know for Hayley, for you, like perineal massage, like that's like everyone
says
thing.
Perineal massage,
and research seems very mixed about it to me. I don't even really recommend it.
And then it's like
to
with
me.
people who do perineal massage, depending on who you ask, like, oh, you should do it every day for like 5 to 10 minutes, or you should do it, not your partner. And then another person is like, your partner should do it, not you. And then another one is like, no, you should do it only like 2 or 3 times a day for only like 5 to 10 minutes. And so it's like, what is the actual recommendation? And then it's like, it doesn't really help you not have a 1st or 2nd degree, but it can decrease your risk of 3rd and 4th degree tears. But how do they know that? Because the risk of 3rd and 4th degree tears is like so low already. Like,
yeah,
how can you like quantify all of these claims about perineal massage?
Yeah, I think the biggest thing is gonna be your provider, right? As much as we want to feel like, as much as we want to have control, right? And all of the things that we do can help minimize our risk is just that. Again, there's some evidence of provider being hands-on or hands-off of perineum and baby during that crowning phase. And what that research found was that there wasn't really a big difference between the severity of tears there, but the rate of episiotomy is much higher with hands-on. So if your provider is hands-on, it's not too difficult for them to go from, this looks like it's stretching a lot, to let me just help this out a little bit. And so that's something to consider. Again,
that's interesting, because I've read the opposite, that when they were hands off, that they didn't know what to do with their hands, so that increased the episiotomy rates, because they're just like, I don't know what to do, I need to do something, I'm going to cut an episiotomy. Versus hands on, they were doing something, so they were distracted.
But in all of those, in those laboring people were all in like a lithotomy position. So you're less likely to be hands-on if you're in different positions, because it's more awkward to be hands-on. I think there's mixed evidence on like a warm compress, or even like perineal stretching intrapartum. I'm a big, some people are like, oh, you can use lubricant. I've seen baby soap.
Oh, don't do it.
I had baby soap on my perineum during my first birth. And
Which blows my mind. Like mineral oil can't be that much more expensive.
well, just think about that.
I think it's just baby oil is readily available in every room. And I don't think it was like fully understood the effects of soap on the microbiome as well as like skin of the vagina. Like the thought process was like, oh, it's just like we're giving baby a bath prior to them coming out. And then like that first pee, you're like, what the F is going on? Because all of that soap.
I remember seeing like drama on like TikTok and Instagram where people were pointing this out that this happens, and then there were providers that would be like, that would never happen. And I'm like, I literally just saw it at a birth where a provider pulled out shampoo.
It's hard, I think, when new research comes out. Because, I mean, people used to do like Hibiclens, like sterilization, iodine all over the vagina to like sterilize it prior to birth. And that increases your risk of tearing like crazy because you're drying out the tissue. Same with baby soap, it's drying out the tissue and increasing the risks of tears. So even if they have an intact perineum with the baby soap, they have micro tears still within their skin that's increasing like discomfort as well as likelihood of infection. But it's like when new research comes out and tells you that everything that you have been doing for however long was wrong and you were inadvertently causing harm, it's really hard to be like, yeah, I fucked up. And I know now, and I know better now based off of this new education, and I'm going to do better in the future. Yes, I did that in the past, but that doesn't, like, when this new research comes out, it doesn't mean that, like, oh, so well, I'm a terrible provider because I was doing all this. But you didn't know. Like, none of us knew all of these things. I mean, maybe some people probably knew, but, like, until research comes out, I mean, like, the freaking umbilical cords. People were using alcohol on these umbilical cords to help dry it out so that they fall off quicker. And then research came out and we're like, actually, that's causing a lot of harm and increasing the risk of infection for all of these babies. Or bulb suctions
are now non-evidence-based, but it's something that people have been doing for such a long time.
Because people are like, well, we've been fucking up for the past, like, we've been doing it wrong. So, like, how could we have been doing it wrong for so long without realizing it and potentially causing harm? Instead of just being like, oh, well, this is a learning opportunity. Let's take this new research and move on with it. Now we know, don't use baby soap. When you're pushing with someone, maybe use mineral oil.
Even so then knowing also your provider's rates of using forceps or other instrument assisted surgical type births, that's going to increase your risk of all pelvic floor issues, right? Forceps assisted delivery, vacuum assisted delivery, and episiotomies really can make that pelvic floor recovery more challenging. That's not to say that there aren't times where this is a necessary intervention, but we just need to be aware of that.
So one of the, and Roxanne, obviously correct me if I'm incorrect on this, one of the reasons that I see providers recommend, usually it's a vacuum, I don't see forceps very often.
Forceps are not
anymore.
Taught
I've seen it maybe
much.
Twice out of my like 5
They're not taught
years.
at residencies very often.
Usually when I see a vacuum being recommended, it's because baby's heart rate is lower during pushing, which is common when babies are getting close to being born because their head is being smushed. And so I'll see providers sometimes recommend it then, and usually these are the more anxious providers. And this is not to say that this is still not a good time, like having informed consent is really important. I've also seen a vacuum used when a baby is starting to not look very good for a longer period of time, like a heart rate was really elevated, which is potentially a sign of infection, or they're being impacted by an infection. And it had been going on for a while, like mom's pushes are no longer like being very effective because she's also getting sick, contractions are spacing out, and the provider is like, hey, like you can keep going, but it's not looking great. Like a vacuum might be a really good idea. Like baby's in a wonderful position. Like we just need a little bit more like oomph to get this baby out, and like you both are declining in health. So that's usually another time that I'll see like an instrument assisted delivery recommended. And again, it kind of depends on the provider's training, and it will be an OB that does
a vacuum or forceps.
Episiotomy a midwife can do as well. So like for me with my first birth, and I actually don't know what was going on because I was pushing for a long time. So if you remember, please fill in the gaps. I think her heart rate was dropping really low.
Yeah, so baby was having what we would call variable decelerations, genus first. So that she was pushing it, baby was like having like abrupt decels, and then and it was just getting deeper and deeper with every time she pushed. And then I don't know for sure, but sometimes the variability. So baby, we never have like the same heart rate. It always like changes within every second. Like you could take your own pulse and there is variability within the heart race where it goes up or down. And potentially that variability could have started going down, which is a sign that baby is not tolerating and not being well oxygenated as well. And that would be a sign that baby needs to come out sooner rather than later, because during the contraction, like you say, like babies, if their head's getting squished, their heart rate is going to go down from just the compression of their head. But the type of deceleration that the baby is having, as well as does baby recover in that 2 minutes in between the contractions, is the cues of whether or not baby is tolerating pushing.
And so hers was not. She was not doing great. And
she
so
was not
they recommended an
but she had been
episiotomy.
pushing for 2.5 hours.
She also had her
was
hand
like squishing her eyeball
by her
with her
fist,
hand
the
because
little
that's where her
black
fist
eye.
was. So I think she also had like a body or nuchal cord. Like she was all sorts
She
of
was
crazy in
not
there.
really helping me out there.
No. So that is likely why she was having those decelerations, because it's usually some sort of cord compression. So if your baby, when you're pushing, has those decelerations and they come out and they have like a cord wrapped around their neck, but they were tolerating it in between, that is not a sign that like something was wrong. It's just like a normal physiologic response to cord compression is you're going to have a deceleration. Or if I squeezed your head for a minute, like you would probably also have a decrease in heart rate. It is what they do in between that matters. And so that's usually when they'll be like, okay, baby is either like their heart rate is starting to rise from their normal baseline, or that variability is starting to get lower and lower. Or when they're having the decelerations, it's going to like the 40s or the 30s or the 50s, which truly couldn't actually, like it truly could go to that low, or it could have just been like the
monitor fell
computer
off.
error.
Yeah.
Their equipment.
So this is not us saying that you should argue with your provider if they recommend instrument-assisted delivery. I do find that it's not a very common thing that folks recommend, but it's just giving you some information if you find yourself in this situation and your provider's recommending it, or if it's something that you feel really concerned about, like having a conversation at your prenatal appointments about, hey, how often do you use like a forceps or vacuum? Which one do you use?
Yes, because not every provider does
what
vacuums or forceps.
What are some reasons that you recommend it? Like, can we go over the risk versus benefit now so that I already have the information if I do need it during my birth? And again, they're not super common by any means.
And with vacuum and forceps, I think the thing people are really scared is like they're like pulling my baby out. Like
you're still pushing,
putting all of this on my baby and just like yanking my baby out. But they're not. They're really, the goal is like they're just gently guiding, usually to help baby get under that pubic bone, to then like you usually, once the baby is like crowning is when they'll take them off, and then you push the baby the rest of the way out. And they're like gently tugging, but I mean, there are still risks associated with like a vacuum, like bleeding on the scalp where the vacuum was applied, as well as with forceps and vacuums, there is the risk of nerve damage. And then obviously with forceps, even if you just think about it, these metal salad tongs are going into your vaginal vaults. It's probably some pelvic floor dysfunction associated with that. But forceps are not, like, I think I've seen like 3 or 4 in my 8 years of labor and delivery nursing. They are not common,
right.
but the 3 or 4 that I've seen, all were successful. Whereas vacuums, I've seen so many more vacuums, but not all of them get the baby out, and then it leads to a C-section if they can't get the baby out.
I think it really depends on baby's head position, because
vacuum is better
forceps,
if baby is in an
if baby's
optimal
in a
position.
funky position, I have found are really successful. I've only seen 2, so I have lots of experience with this. But the vacuum, if baby's head is not in a pretty
Not
good
helpful.
position, it's much harder to get them underneath that pubic bone. But just some things to consider when it comes to pushing, but knowing that if you do have instrument-assisted delivery, it could impact perineal tears, which is increasing the risk of like those 3rd and 4th degrees. And then obviously
Some
pelvic floor
providers
PT.
will cut an episiotomy prior to forceps or a vacuum, depending on how big your like vaginal opening is. So some people, like everybody has a different sized opening. Surprise. So some people just naturally have smaller ones that don't stretch. Like, I mean, if your baby's not like stretching it out, like it's harder to stretch it with forceps, so they'll cut episiotomy. So that would be a good question. If your provider does vacuums or forceps, and do they also cut an episiotomy when they place that? Because obviously, if you think about it, if they cut an episiotomy and then place something inside your vagina, this is going to increase the likelihood that it's going to extend into a 3rd and 4th degree tear because that tissue is no longer strong.
So I do want to add in one thing when it comes to making the decision between having instrument-assisted delivery versus going for a cesarean birth, knowing that instrument-assisted delivery may result in a more severe tear. And this is just something that I felt like would have been really important to me to know in the moment, like if I was there, and not everyone's going to feel the same way. For me, if I had had a instrument-assisted delivery, it does not impact my future birth options. I am just considered to be somebody that had a vaginal birth.
Well, you had an operative vaginal delivery.
Yeah, but like it doesn't change. Like I am not restricted in like how I can be induced or where I can give birth or things like that. While if I had a C-section, it would impact my like birth options for future birth. Like I couldn't give birth at home with a licensed midwife, like in North Carolina state. I couldn't, like some states you can though, so that's not always a restriction. Like if I had to be induced and I was a VBAC, there may be limitations on how I was induced. Like, and I may be met with different types of conversations during my pregnancy as opposed to having an operative vaginal delivery. So that's something to me, like I wasn't in a situation where I was like C-section or episiotomy. Like it was just the C-section was never brought up to me.
Yeah.
But if I was in that situation, I would have wanted to know that this could really impact your future birth options depending on which you choose. This doesn't mean that you have to choose operative vaginal delivery. You may be like, I'm good with it. Like I would rather.
Yeah, and some people would much rather choose
because
the
3rd and
C-section,
4th degree
and that's
tears
fine.
are still something significant to heal from. Now, I don't know what the comparison is because I haven't personally had a C-section and a 3rd or 4th degree tear. I've had some like clients that have had both, but everyone's an individual too. So like how you might heal from a 3rd and 4th degree tear will be different than how you may heal from a C-section too. So I don't even want to say like, oh, it's better to have this versus that because we're all individuals as well. But I would have wanted to know that.
No, that's
that
a really
moment.
good, important key to include in the consent of forceps and vacuums.
Yeah, I think on the flip side of that, I've had a few clients who had forceps assisted births with levator ani avulsions and significant pelvic organ prolapse because of those types of injuries. And for their subsequent births, that was like a very clear conversation that was had prior to giving birth, was there will absolutely be no instruments used, and if that's the scenario that's coming up, then we will progress to a C-section. And that's like the beauty of collaborative, respectful, maternal care, is that we can have these conversations, we can talk about the risks, benefits, and alternatives of all of them, and being able to have a provider that's willing to have those conversations with you, I think is really telling of how they'll behave when you're actually in labor as well.
Absolutely.
Another risk factor, and what I saw, and I'm curious if you guys see this too, is one said anything other than like OA positioning, increasing your risk of tearing. So OP babies, and maybe even compound presentation, so like hand up by the face, being a higher risk of
probably because so like the compound hands, or even just so compound hand is the head and the hand coming out at the same time, so it's like a larger circumference because the hand is there. Or even if baby's hand is just up in a funny position. So like instead of their elbows kind of like being tucked into their chest, one of their elbows could be like sticking out a little bit. And if you think about it, like that elbow is just like dragging along the vaginal vault as that baby's coming out, and can sometimes cause a tear. So it's like the baby's position plays such a big part in like what's happening.
It's less common, I think, for OP babies to be born vaginally in the hospitals that we are at. Because those babies usually just have a really hard time making the rotation under the pubic bone to then start crowning. The only OP baby that I've seen born vaginally was with forceps.
I've seen OP babies born vaginally, and they usually do have a tear. Most of the time, though, when I've seen them like pushing, they are not a first-time mom OP. They're usually like a second or more first-time like birth, like babies coming out of the vagina kind of birth. And those ones it'll be odd because they be pushing for longer than you would normally expect a second or third or fourth time, especially if their previous births were like fairly quick for pushing. Then we're like, oh, that's why.
If I have more than like a 5-minute push this time, I'm gonna.
I was convinced
deteriorate.
Joan was gonna be OP based off of how long I was pushing. I was like, this girl better not be facing the wrong direction or the unoptimal direction because this is taking forever. She was not. I can't remember. I don't think she was OP.
I think she was just bigger.
Maybe she was at the beginning and rotated because that's usually that's why it takes so long is because they rotate from OP to O8 while you're pushing. So that's why not a lot of them are OP, but they will have usually will have some sort of tear if they are OP. I've seen if they're asynclitic too. If they come out a little like crazy, like sometimes they'll have like those labial tears depending on which way the head was turned. But the compound hand or like the elbow sticking out, I will say I've seen one. This was just like an unfortunate, the baby, as the baby was coming out, like the baby, like the leg kicked.
No.
And just like kicked right through the perineum. I was like, oh, the provider was like, just catching the babies because they really just come out and like slither out. And the baby, we saw the baby's like foot moving in like slow motion. And then you just see the perineum tear. And I was like, what? I've never seen it like that. What just happened? And she's just like,
well, that tissue was probably so thin and like
God.
so fragile.
It was intact. And then the baby just hit it just right. And you just saw it just
Future
split.
soccer player.
Yeah. I mean, it was only a first degree, but I was just like, what the heck? This baby.
Like, come on.
But yeah, the position of baby definitely plays a huge part, but also the position that you push in has a minor part because gravity is going to pull baby down. So I've only really seen periurethral or clitoral tears, like full on tears, when someone was hands and knees, interestingly enough. And those ones, when she was unmedicated, hands and knees, and then tore towards her periurethral. So we had to place a Foley while they repaired it because they're like, we want to make sure we don't, suture your urethra closed.
Yeah.
And she's like, I just did this entire birth unmedicated and now I have a Foley. This is some shit.
Yeah, no.
And I will say my clients that have had periurethral tears or clitoral tears, I think sometimes it gets categorized as like first degree or minor, but they can be so painful. They can be really, really painful.
I mean, superficial skin on the clitoris. Are you kidding me? Should be a fourth degree clitoral tear.
There's tens of thousands of nerve endings in there. Yeah.
Yeah, just oh my gosh, so painful.
Let's take a break from this week's episode to talk about our podcast sponsor, Needed. Needed is a nutrition company that focuses on optimal nourishment for the perinatal timeframe. It is a brand that Roxanne and I have both used during our pregnancies and our postpartum to help supplement our nutrition. One of the things that's really important to continue to take even after you give birth is your prenatal vitamin. We have a lot of folks that'll message us and ask, what postpartum vitamin should I take now that I've given birth? You could just continue to take your prenatal vitamin because it's providing a lot of the stuff that you need postpartum to help support your healing and address the nutrition that you need.
We both have taken Needed's prenatal vitamin, and they have 3 different versions. They have a prenatal multi-powder that is like powder form that you can add to food and has a vanilla flavor. And then they also have their prenatal essentials, which is just 3 capsules, or their actual prenatal capsules, which is 8 capsules. So they all offer different nutrients and amounts of nutrients, but they're all very intentional with the amount of nutrients that they're providing in each one. The essentials is the lesser capsule, so it doesn't have as high of the nutrients as the other 2 options. But if you don't like a lot of capsules, I like that they have that option for people because it's just 3 capsules and it's a lot to swallow 8 capsules in a day. So they have options for all of the different types of prenatal variations that you would need. So they're using the optimal forms of all of these nutrients that our body can readily absorb and actually utilize. We have both taken their prenatal vitamins. We used their powders during our first trimester when we were really into capsules or eating much. And then we've transitioned to the capsules because they're a little bit easier to add into your daily routine. And I'm still taking them in this postpartum as I breastfeed, as Gina is in her first trimester.
If you want to check them out, you can check them out at thisisneeded.com and use code MAMASTAYPOD to get 20% off your first order or 3 months of subscription. So let's talk about what someone can expect for like healing of the perineum. Like we'll start like initially postpartum, like what they could expect with their nurse. And we can discuss, Hayley, whether or not you think that what is happening in the first like 24 hours is beneficial. Because I know there's some new stuff about like ice is not great long term.
Right.
I've heard like the first 24 hours it can be helpful, but then after that, like don't prepare like 85 padsicles.
I think it's also just like
beforehand.
person dependent. It's so person dependent too, because some people like ice doesn't even feel great for them.
Yeah.
And some people are so swollen that they need ice.
So let's start with what can someone expect in the first like 24 hours postpartum, like with their nurse.
If you deliver
and with
at a
their
hospital, you'll get your peri bottle with warm water. It's your best friend, and that's going to decrease like the amount of discomfort you have, as well as like you're not going to take a towel to your perineum to clean your bottom. That's just not going to happen. It's super sensitive. You're just not going to do it. So the peri bottle is a gentle way to clean it, because we want to clean it. We want to keep it clean and dry, as dry as possible. Obviously, you're like still bleeding. They're going to give you ice packs, and the ice packs will stay cold for like 30 minutes, if that. But that's going to help decrease if you have swelling of the vagina, because that's going to cause more discomfort. So inflammation is what happens when we have trauma, because you're increasing the blood flow. But that can also increase the amount of discomfort that you're experiencing until that swelling kind of goes down. Some people, like if you push for 5 minutes, may not have a ton of swelling. Some people who push for 45 minutes to 2 hours are going to have more swelling. So different people will require more or less ice. I did find when I had pushed for 45 minutes, I wanted more ice compared to my one birth that I pushed for like 5 seconds. I didn't really need the ice for very long. I think I only used it for the first 2 pads. And then I just had like 49 ice packs at home, which was, I still don't know what to do with them because I feel bad throwing them
People
away.
always bring them to the gym to donate, and I'm like, no one needs these.
Because you really only need it the first 24 hours, I feel like, after birth, because that's when the most swelling occurs. And then after 24 hours, most of that swelling has gone away just naturally. And ice is only really beneficial for the swelling. I will say I did use ice packs on my hemorrhoids and like my butt pain after that first 24 hours, and that did feel good, but I would just put it on my butt. I didn't really put it on my like perineum because hemorrhoids. But Tux pads are another, witch hazel Tux pads are another really great thing to help with swelling if you didn't want to use ice pads. So Tux pads or witch hazel, like it's like a astringent. I don't know if that's the word, but you put them on your pad and then you just put them on your bottom, and it's like cooling for your bottom, and it feels really, really nice, and also really great for hemorrhoids if you had hemorrhoids. And then the other thing that they'll give you is some numbing cream. They'll either be EpiFoam, which is like a foam that you can place on your pad, or Dermaplast or Dermablast. I can never remember which one it is. I think it's
Blast.
But you spray that either on your pad or just directly onto your perineum. And both of those are like numbing, cooling agents for your perineum.
I found the EpiFoam really helpful when I had an episiotomy because it was
really
just
nice.
a lot.
It's hospital dependent on which one they give you. So like the one that we delivered at with our first, that one gives EpiFoam, whereas the one that I recently delivered at gave Dermaplast. So it's just hospital dependent on which one.
I feel like the spray sometimes is like kind of jarring when it first like,
yeah, it can be
it's
a
in
lot.
an aerosol sometimes from the hospital too, but the foam where you can just like pat it on. Yeah, I feel like there's been big shifts in the rehab world, sports injury world, which sure we could classify this as around ice and really around anti-inflammatories, and that the idea is that when we swell and we get swelling, that swelling is bringing all of these healing factors to the area that needs healing. And so now sort of the recommendation is, don't, you sprain your ankle, don't ice it. Instead of going like the rest, ice, compress, elevate of our whole lives, it's now this acronym is now peace and love. And so, and I think that we could apply this to the perineum pretty easily. But I will say from a pain management standpoint, I really don't have arguments around using a little bit of ice in that early, initial period for pain management. I think if we're thinking that a little bit of ice in the junky hospital crack packs that last couple minutes is going to diminish your inflammatory response and hurt your healing, I don't think that's true. I think if you're icing it to the point that your skin is really cold and frozen, okay, maybe. And for a really prolonged period.
Cold.
But I would say if you have had a major tear and that's the only thing that's offering you pain relief over, the days and weeks, then I'm not gonna say stop icing. That's gonna wreck your healing. But if the ice isn't offering you anything major, maybe the inflammation is okay, and that we want to use maybe things like compression or gentle movement or breathing strategies to help us minimize that swelling and inflammation as well. Or the sports med bros are very anti-ice, but bizarrely they love an ice bath. So I don't know.
I will say the cold plunge, they don't my husband is really into the cold plunge. We have one of those Edge Theory cold plunges in our house, but it also can be warm. So I use the warm, we call it the warm plunge. But they don't do it after working out and to help them recover.
Right.
It hurts muscle growth if you do it after.
You do it before you work out to amp up your body.
Right. The other nervous system response.
Yeah, I'm amped up for this workout, I guess. And it also has benefits, they say, for other people who have depression, anxiety, to help their stress response and anxiety response. But
so my favorite postpartum ice hack is actually to use a baby diaper and to cut the back out of it and then fill that with ice. It won't leak all over and it's going to get a little colder. So that was my kind of trick with both of my that first kind of 24 hours.
And the diaper will absorb your bleeding.
Yeah. Yep. That as well. But I don't know. I'd say maybe if I were to have another one, maybe I wouldn't ice. Maybe I would just see what happens without.
It just feels so nice. That first ice pack just feels so nice.
Yeah. So I don't know. I'm not sure.
It's just very sensitive.
Yeah. It feels really nice. But sitz baths. So after I think I did 12 hours probably, mostly because I forgot after the first 12 hours of ice. And then doing a sitz bath feels so much better after that first 12 to 24 hours, doing a nice warm sitz bath, whether it's in the bathtub or actually sitting on the tub and you just fill it up with warm water. You honestly only need warm water. You can add in all the other herbs and whatever you add to a sitz bath if you want to. But honestly, you really just need warm water because, like you say, the warm water increases that blood flow to that area to aid in healing. Also really great for hemorrhoids, with many of us do get, probably not for a good reason, but they happen. You just deal with them. But sitz baths are really great for hemorrhoids as well as perineal tear laceration healing, because it's one, increasing the blood flow to allow and aid in healing. But it also feels really nice as well because that tear, as it starts to heal, it gets itchy and uncomfortable because it's dry. And so you can put like creams. I think, Gina, you said you really liked creams for
Kinda
your
like a balm.
episiotomy, like a balm once it was like dry and itchy, but like a sitz bath would also be a great alternative to that.
Yeah.
So let's discuss like the longer term healing of perineal tissue. Obviously, this
After 48
podcast will
hours, I
give
got
somebody
nothing.
like a ton of information, but it's not going to give you all of the answers because we're limited on time. Like, what could someone expect like at like their first pelvic floor PT appointment? I know for me, I had to really advocate to get a pelvic floor PT appointment. The OB was like, are you like peeing yourself? Like, why do you need one? And I was like, I don't know. I pushed a baby out of my vagina and I had an episiotomy. Like,
And you carried a baby for 9
I
months.
feel like that should be more than enough reason
Right.
to go see a pelvic floor PT. Like, I have to be peeing myself. Like, I'll piss myself right now if that'll make you
Yeah.
give me a referral. Like,
You want me to pee?
Whereas for me, I was like, could I
if
have
that's
a
the only
referral?
criteria, like, I'll do it. What could someone expect at their like first PT appointment? Obviously, like every PT is a little bit different, and some tools that they could use to help with that, like perineal scar massage, because like we've talked about like C-section scar massage is like incredibly beneficial, but there's not as much like information and content being delivered about perineal massage, and it's probably because it's really hard for someone to show their vagina on Instagram and not get like banned. It's really easy for me to draw a line on my belly and show like scar
Just
massage
use my
techniques.
finger. This is perineal massage.
So what could someone expect to help kind of enhance that healing in the longer term postpartum, which I know is a very long conversation.
Yeah. So one, advocating for public PT, I think, depending on your state, you don't need a referral. So we can sometimes just bypass that whole situation if they're going to be a pain in the butt about it.
Insurance, though, is also so crazy,
yeah,
too.
sometimes it's an insurance thing as well. The good old, can you document that you've denied this referral in my chart, is sometimes a more confrontational way to do it. But I think in general, just say, hey, I really would love to go see a pelvic floor physical therapist. I actually know of one. This is her information. Can you write the referral for this specific individual? You've gone armed with the information. And then you've already done like half the work for them. So, it's there.
It's a lot easier.
Or if they're like, are you peeing your pants? You go, yes. Yes. Sure. You might not be peeing your pants, but yeah, I'm peeing my pants. Or, I'm having a lot of pain, or, whatever you need to do.
To get your referral.
Yeah.
We're not promoting lying.
Yeah. Again, but I think if you feel like you have to lie to your provider to get the care that you very justifiably need, it's probably a good sign that it's time for a new provider. So I'm a big fan of firing providers if they're not. And in a military system, I know that's always a little bit harder, but it's not impossible. So there's that. I think the longer term is that part of that like peace and love acronym. So the love acronym is for as we go further on. One of the O in love is is optimism. And so the mindset piece of that, and then acknowledging that there can be a lot of feelings that go along, and a lot of emotions and a lot of worry that can go along with how our vulva looks, how our vulva has changed because of this scar, these worries about damage that has been caused. And so just like we often start with cesarean recovery by just touching it indirectly, maybe just sort of seeing what feelings come up when we touch it, maybe touching around it, maybe starting to look at it. Those same principles can apply to a perineal scar. And acknowledging and recognizing and giving yourself room to feel maybe a little uncomfortable or feel a little bit unsure, and know that those are totally normal things to come up, and that people like your pelvic floor therapist or a mental health therapist can help you work through some of those feelings, because it's really hard to heal a part of our body if we're feeling crappy about it, right? It's like, oh, my vagina looks like hamburger meat. I've literally had a patient been told by a provider that that was the situation after she was born. And so she's going to internalize that statement. And when we actually looked at it, we pulled a mirror up to it. We took a beat to say, like, it actually looks amazing. It looks just like it did before. It wasn't hamburger meat as she had imagined in her mind. All of her symptoms got better. And so that kind of stuff is also really important. I don't think gets talked about enough in terms of recovering from these types of tears. Usually if a patient's comfortable with pulling out a mirror, usually people are amazed at how it's recovered in 6 weeks and how normal it looks. Yes, there's sometimes changes. Yes, sometimes tissue's a little bit more dry, but usually people are pretty amazed at how well it heals. So just having good feelings about it is a good place to start. And then another part of the V of that LOVE acronym is vascularization. How can we enhance blood flow to this area? We can enhance blood flow in this area by starting to optimize our breath and breathing. So getting our diaphragm and pelvic floor coordinating our abdominals and our pelvic floor, starting to use some of the muscles of our hips and inner thighs. All of that is going to bring really good blood flow to our perineal tissues and help it heal. And then we can do some hands-on techniques on perineal scars to help mobilize them and move them. And it would be similar to how we would use something like perineal stretching in birth. I tend to be non-aggressive. I don't want you to hold it and stretch it and it to hurt, but we're trying to see, can we apply a physical stimuli to this tissue and then breathe and feel how we're sort of doing combo sort of self-mobilization with our breath in those situations. You can use things like pelvic wands and different types of pelvic wands maybe have vibration, so we can bring a little bit of like pleasure into this situation here. We can activate some of those nerve endings that feel good. That will also help with blood flow. That will help with that tissue extensibility. And that decreased sensitivity in the area. There's other pelvic wands that have hot or cold capabilities, so we can sometimes implement some of those if it's more of a temperature sensitivity or texture sensitivity, all sorts of things that we can also see with people who have cesarean scars as well. And then beginning to introduce exercise and movement at the appropriate timing, that's going to also help mobilize our scar tissue. Again, just like we can't just do cesarean mobilization on the scar itself. We actually have to move our bodies and our rib cages and our pelvises and our breath in order for that scar to mature fully and get the different layers of that tissue moving together well. Same thing with our pelvis. But I think so often when we have fear around that pelvis and pelvic floor, we just are holding it tight and we're gripping it and we're not letting it move and we're not letting it breathe. And so the more we are comfortable moving our body and moving our pelvis and our rib cage, the more opportunity that scar has to mature and thin down and heal really well. And so all of that, initiating that early is really helpful.
Thank you. That was a lot of really wonderful advice. I know for me, after my episiotomy, I don't think I did any sort of like scar mobilization for like the first year because I just didn't realize that that was something I should be doing until I was having difficulty activating like on my left side, which was the side the episiotomy was towards. And once I started introducing like mobilization to the tissue and like utilizing a pelvic wand and helping to just kind of increase the movement on that side of my pelvic floor and my perineum, I found like so much relief from like discomfort that I was having and movements that felt like inaccessible to me and my body, like just felt so much better. Scar mobilization on the perineum also can I think it helps to increase the integrity of the tissue, which could help for subsequent births as well. So usually when my clients have a second tear in a subsequent birth, it's usually along the same line as their prior birth. And so doing the mobilization could also help to increase like the strength of the tissue because it helps the tissues heal better, which could potentially decrease the risk of tearing in the future as well.
Absolutely.
So thank you, Hayley, for sharing all of that wonderful advice.
Of course.
And I still kind of do mobilization techniques myself that I learned after like my prolapse, seeing a pelvic floor PT with my prolapse and like learning some techniques. I still will utilize if I'm having some sort of pelvic pain or even like certain things that I'm feeling are like, oh, like kind of funky. I'll do like some gentle mobilization, like not even like internal, just like external mobilization of like the inner thighs as well as that scar. And I'll feel like a ton better usually, like within the day. It's amazing.
The perineal body itself is such a junction point of a lot of different things. And so it can just be stiff. It can just be kind of tense. And so, yeah, just some really gentle self-exploration work can be really, really, really valuable. Mm-hmm.
Well, thank you so much, Hayley, for coming on the podcast and talking all about perineal tears or perineal lacerations with us and things that we can do to help decrease the risk of tearing, and then also how we can approach recovery if that does happen. How can our listeners learn more from you on social media, your website? I know that you offer a monthly, I think, pelvic balance course, which is virtual, which is pretty awesome.
Yeah, yep. I am at Hayley Kava PT on Instagram, and that is the same. My website is www.hayleykavapt.com. I do a monthly Pay What You Can pelvic balance series. This is the first time we did it, Pay What You Can, and I think we're going to keep it that way because it's been super, super fun. And that's just a 4-week sort of introductory series to thinking outside of the box and looking at the whole body and how it impacts the pelvic floor and movement. I work with people one-on-one online, and this summer I will also be seeing people at Mom Stay Fit. So stay tuned.
Yeah,
stay tuned
which
for
I'm
that.
very excited about. I've been telling everybody that's been joining the gym, I'm like, just so you know, we'll have a pellet for PT here in house in like a few months. Like, just hold out.
Yeah. Well, they don't have to hold out, but
well, everyone's moving or like not taking clients anymore.
yeah,
and I'm
it's
like,
PCS season, so life is everybody's all over the place.
Well, thank you so much, Hayley, for coming on the podcast and sharing your wisdom with all of our listeners again. And we're really excited for you to come back to Southern Pines and be in the gym with us for a lot of really fun and exciting projects that are planned for the summer. So thanks so much for coming on the podcast.
Well, thank you.
Thank you so much for listening to this week's episode. If you enjoyed this episode, we release new episodes every Wednesday and new birth stories every Friday. If you're pregnant and you want more support throughout your pregnancy, you can join our online prenatal fitness programs and childbirth education course, and you can bundle them both to save 15% off. If you're postpartum, you can join our postpartum education course, our early postpartum recovery course, which is a free offering for you, and our postpartum fitness courses to return to fitness and to recover after birth. If you're a professional and you want to earn some CEUs, you can join our birth worker course and our prenatal postpartum fitness trainer course.
And as a thank you for listening to this entire episode, you can use code STORY10 to get 10% off any of our courses or fitness programs as a thank you.
This podcast is sponsored by Needed, which is a nutrition company focused on optimal nourishment for the perinatal timeframe. Roxanne and I have both used Needed throughout our pregnancies and our postpartum, and so they're a brand that we trust and highly recommend to you. If you would love to check them out, you can check them out at thisisneeded.com and use code MAMASTAYPOD to get 20% off your first order or 3 months of subscription.